Sergeant Bykowski, and this chapter is Airway Management. And we will dive right in. Alright, so Airway Management, we'll talk about a bunch of different things. Is initially the anatomy, just to get your brains kind of going with a refresher with that. Then we'll talk about the differences between artificial ventilations, normal ventilation, and then kind of different rates for breathing and such for adults to children. All right, so respiration. Respiration is actually you breathing in and breathing out, where ventilation is the artificial ventilation, which is like using some sort of like a bag valve mask or like mouth to mask, where you're physically ventilating an actual patient. So just know that respiration is like your body, like your body system's actually doing that exchange of air, which in turn is giving you gas exchange on a cellular level. Kind of just went over that. The biggest thing is to obviously recognize that there is some sort of discrepancy or some sort of issue with the breathing, whether it's the quality of breathing, the quantity of respirations, and then kind of picking the best method, best treatment to help kind of fix that issue or temporarily fix that issue until they can get to definitive care at the hospital. Your respiratory system is kind of divided up into two different sections. This is your upper airway and your lower airway. Upper airway is more essentially from like your Adam's apple or your trachea up, and then from your trachea down would be your lower airway. So, and I think I'm probably getting ahead of myself. There will be a slide coming up of a picture of the anatomy with everything kind of labeled. So we'll just wait for that to come up to go over and get a better idea, get an illustration of the anatomy of both the upper and lower airways. So like any living thing, there needs to be food, water, and oxygen. Obviously, with respiration, we're talking about getting the oxygen into in that equation. Your body can only last a couple minutes without oxygen before having irreversible damage, or if nothing gets corrected, potentially death. But that is everything from breathing, so you're pulling in that air from the atmosphere or from your environment. You're pulling that in through your mouth or your nose or both. Bringing that air into the back of your throat to where your larynx is, down to your trachea. We'll touch upon or refresh your memory that your trachea has, at the opening of your trachea, there's that leaf-like tissue called the epiglottis, which will cover your esophagus, which is located immediately behind your trachea. When you're breathing, to let air into the trachea but not into the stomach, and then when you're eating and or drinking, then that epiglottis will actually flip over, covering the trachea to not allow food or liquid into your trachea and in turn into your lungs, and will have all the food and drink go into your esophagus, and subsequently go into your stomach. Here we go. So, like I was trying to wait for, but obviously I couldn't because I was so excited to tell you about the anatomy. We'll start with your nasal pharynx and your oral pharynx. So your nasal pharynx, your nostrils have a nasal passage that goes to the back of your throat. So your nasal pharynx and your oral pharynx both meet at the back of your throat, which is your larynx. That will go down to your trachea, like I already stated, your trachea and your esophagus. Sits one in front of the other, and the epiglottis is in between, which is, like we already said, cutting off the openings to your stomach and your lungs, depending on what body function you're doing, whether it's breathing or eating or drinking. Then once you go down to, so if we're talking about air, we're talking about respirations. Your epiglottis is covering your esophagus. Air goes into your trachea. Your trachea goes all the way down to your bronchi, which is like those, they look like roots of a tree. So they branch off into each lung, and then you have several other branches off of the bronchi, which are called your bronchioles, and that goes throughout your entire lung, your lungs, and then even smaller at the end of your bronchioles, you have your little pulmonary capillaries, and that is where the gas exchange happens. So you breathe in with a deep breath, pulling that fresh oxygenated air into your lungs. Once the oxygenated air gets down all the way to the pulmonary capillaries, that is where the gas exchange happens. So you're taking that freshly breathed in air and oxygenated air. The oxygen gets transported into your bloodstream, and the carbon dioxide from your bloodstream, from all your body organs and things, get off, just like the fresh oxygen comes into your bloodstream. Carbon dioxide gets out of your bloodstream into the pulmonary capillaries, and when you breathe out that carbon dioxide. It's important to know that so the air that we breathe in the world only contains roughly about 21% oxygen. So it's important to know that you breathe that 21% oxygen in with that air, gets transported through your bloodstream to all your organs, to your liver, to your kidneys, to your stomach, to all the living parts of your body, all the organ systems, gets a little bit of oxygen to each of those things, and it pulls carbon dioxide, or that used oxygen that it has turned into carbon dioxide from those organs into the bloodstream, and then brings all that carbon dioxide back to your lungs so you can breathe it out. And you're actually breathing out somewhere around 15, 16, 17% oxygen. So your body's only like using or metabolizing 5% of the oxygen, of the 21% of oxygen that you're actually breathing in. So that's why mouth to mouth is useful and is a acceptable way of trying to resuscitate somebody, because even though I'm breathing out oxygen into somebody's mouth, or if I'm doing mouth to mask or mouth to barrier, I can breathe out air into their mouth to go into their lungs, because even though I'm breathing out around 15-16% oxygen, they're still going to use 5% of that, so there's still 10% of oxygen left over that I'm breathing out. So that's why that is able to be used like that. But yeah, so just to recap, because we kind of just went down this pretty complicated rabbit hole there. You breathe in the air from your pharynx, and I believe I misinformed you in the beginning. Your nasal airway, your nasal pharynx, your oral pharynx go back to the back of your throat, which is your pharynx, and then where your trachea is located, kind of in your throat, in your neck lower, that's where the larynx is. But you get your air all the way from your environment into your bronchi, bronchioles, and your alveoli, which has all your pulmonary capillaries covering that, and that's where the gas exchange happens. Oxygen goes into your bloodstream, fresh oxygen from breathing it in, and then your carbon dioxide from all your used blood from the rest of your body gets transferred into your lungs again, so you can breathe that out. And that's how that works. So essentially this slide is just kind of saying that, well, it's actually saying two things. So there's your air passage is, you have obviously your nose and your mouth. That's two ways for oxygen to get in and out of your body, right? So keep in mind that when you're if you're giving mouth to mask, you need to, especially mouth to mask, you have to pinch the nose, make sure the nose is closed when you deliver your rescue breaths to the mouth. On kids will be, because their anatomy is so much smaller, sometimes, especially with infants and the smaller aged kids, you'll be able to use, it'll be easier for you to cover, in some cases, depending on the person, cover both their nose and mouth with your mouth if you're doing mouth to mouth. But that way, both of those things are covered and you're delivering oxygen through both of those ways. But if they're not both being utilized, in that circumstance, is really the only thing I can think of. You're going to be having to cut off each other way. So if I'm doing mouth to mouth on an adult, then I'm going to have to pinch the nose. And I think I'm getting ahead of myself again, because I believe we'll touch upon trachs and stomas and things of that nature later, but I think it's pretty far into the PowerPoint, so I'll just note it now that if you have someone with a trach or a stoma, that little hole in the base of their throat that they use, if you have someone in cardiac arrest, or you have someone that you need to deliver rescue breaths, whether that is mouth to stoma or mouth to mask, or using a bag valve mask, you're going to have to give those breaths, give that, however you're doing that artificial ventilation, you're going to have to do that from the stoma, and then you're going to have to cover the mouth and the nose to make sure air doesn't go back out that way. So just keep that in mind. Whatever hole that you're using to deliver ventilations through, you have to make sure the other ones are covered. And then also they talk about, which we've talked about in CPR, we've talked about in other, touched upon in other segments of the class, but your airway, your tongue is kind of like the number one thing that will block an airway, especially if we're not experiencing any sort of foreign body obstruction. So you're going to have to use your head tilt chin lift or your jaw thrust maneuver to essentially clear the tongue from blocking the airway. So make sure that you have a good understanding and a good grasp, pun intended, on the airway maneuvers. This is just an illustration to show you that a person's tongue could be blocking the back of their throat, blocking air from getting past the pharynx into the larynx and the trachea. Um, so you need to use that head tilt, chin lift, or that jaw thrust to manipulate the tongue and create a non-obstructed airway. We did talk about it. At the back of the throat, there's the esophagus. In the trachea is like your Adam's apple. It's in the anterior part, so like the front of your body, and the esophagus is behind, like posterior part of your throat. And that epiglottis is just a leaf-like thin tissue that, like we already said, stops food and drink from getting into your lungs and stops air from getting into your esophagus and eventually your stomach. Obviously, that doesn't always happen because, just like you and I have several times, people might take a drink of water and choke and start coughing because it went down their trachea, right? That's why you might eat something or drink something and start coughing, and because it went down, commonly you'd say it goes down the wrong tube, and that is essentially what it did. This is kind of going all over what we just went over. This is just to give you a better, more detailed illustration of the more complex, intricate part of the gas exchange, which happens in the alveoli and the pulmonary capillaries. So as you can see, it's just illustrating that oxygen-rich or oxygen comes from the outside environment into your lungs, gets put into your bloodstream as oxygenated blood, and the used oxygen or CO2 from feeding all the body organs comes back to your lungs through your veins, which is deoxygenated blood, and that gas exchange happens when you breathe in and out. So the lungs are soft, spongy tissue with no muscle. Your lungs are actually can become hard or rigid or lose that elasticity from damage, right? So obviously, like the biggest thing that I can think of that would make your lungs not those things, soft, spongy tissue, with is smoking, right? The smoking will harden and lose that elasticity of your lungs, which make gas exchange more difficult and create other damage to your lungs that'll manifest as like COPD, emphysema, things like that. But because your lungs are this soft tissue and like spongy tissue, it doesn't have a structure. So that's what your diaphragm does, right? So your diaphragm helps, your whole breathing is used out of pressure, right? So when you breathe in, you're creating all this pressure. Your diaphragm moves down, which contracts, and by your diaphragm moving down and contracting, it's allowing your lungs to expand and draw in by pressure the air from the outside. And then once you get all that air into your lungs, then your diaphragm will relax, and when it relaxes, it moves back up, and then which in turn, because it's moving up, taking up more real estate, it's pushing your lungs up, which makes them smaller, pushing the air out of your lungs into the atmosphere or the environment. If that helps kind of decipher this slide for you. And that is a illustration, if you're a visual learner, to help talk what we're talking about. Take a deep breath in, your diaphragm contracts, pushing. You see how like your pleural space is what your lungs are inside, so that's allowing the pleural space to move down, which is drawing oxygen in, and then when your diaphragm relaxes on the right side of your screen, it's pushing, your diaphragm's pushing that pleural space up, essentially making that space smaller and pushing, in turn, pushing the air out of your lungs. So that's the air system, pressure system that your body uses to breathe in and out. A is for airway. Obviously, our big things as EMRs, or you hear in the medical world, is ABCs, right? Airway, breathing, circulation. Airway is very important. We obviously need to breathe. We need a patent airway to have continuous life. And we always have to be monitoring that and making sure that the airway is patent. This is just talking about, especially you've had your CPR class. When you find somebody, and you're trying to check their responsiveness. If they do respond to you, without, I'd say, not without difficulty, but without issue, they're able to speak. They do have a patent airway. That generally speaking, someone who can talk to you, their vocal cords are able to are passing air and are able to move to create words. That means that their airway's patent, right? Because you need air to pass through your vocal cords, which is down in your trachea and your larynx, to be able to speak. So that's why you would say that they definitely have a patent airway. If there's no response, then we have to verify and treat someone and give them a patent airway if they are found not to have one. So that might be your head tilt chin lift, that might be your jaw thrust, that might be putting an airway adjunct in, your OPA, your oral pharyngeal airway, or maybe a more advanced paramedic might place endotracheal tube, a combi tube, some sort of airway adjunct to secure an airway if a person's unable to keep a patent airway on their own. If this is more like a lay responder kind of thing, but if we get to a call, so like most commonly, right, we'll go to like overdoses, and if the person's unresponsive, the medics are coming anyway, but typically we're pretty good about getting on the radio and requesting those resources, verifying that they're on their way, so making sure that we're not calling 911, but verifying that other resources are on their way via dispatch, and then getting to whatever treatment that you need, life-saving treatment in that case of having a patent airway, and making sure that they're breathing and have a pulse. Obviously, if they do not have a pulse and they're not breathing, we know what we need to do for that, and that's our CPR with a pulse and not breathing, or not breathing with a appropriate quantity or quality of breath. Then we might have to breathe for them as well. It's definitely not uncommon to have to breathe for somebody, even though they're still technically breathing. Someone who has those agonal respirations, that like one breath every 10 seconds, that's not really going to sustain life. Like we're still just, even though they're breathing technically, maybe like 6 times a minute, that's not going to be good enough. That's not going to sustain life, so we're going to have to breathe for them, because as we know from being EMRs, that you have to have the normal range for adults is one breath every 5 seconds. So, one breath every 10, 15 seconds isn't going to cut it for us. In kids, it's even smaller, right? One breath every 3 seconds for toddlers and children. We've gone over it, or at least touched upon it, but your head tilt chin lift is going to be your one of your ways to open up an airway, and your head tilt chin lift is utilized when you have a person who you do not suspect to have any trauma or neck or spinal cord injuries. So that's your typical person, a traumatic incident, and we need to open up their airway to make sure they have a pained airway, or stop a blockage like their tongue. Head tilt chin lift. One hand on the forehead of the person, the other hand at the jaw or the chin of the person, and you're just pushing that airway back open, as depicted in that slide there. And then I don't think the video is going to play, Shay, so we could skip the video. I don't usually play it. Then you can move on to the jaw thrust maneuver. The jaw thrust maneuver is used if you suspect a neck injury or spinal cord injury. So we go to a traumatic call, car accidents, some sort of trauma to the head, neck area. We think that they have some sort of spinal cord injury, or we suspect that it is possible. So as a precaution, in order to not either cause an injury or worsen an injury, we'll use the jaw thrust maneuver. Jaw thrust maneuver is keeping the head in the neutral inline position, so we're not manipulating the neck at all, and you're taking the meaty part of your palms, which is the part just under your thumbs. The meaty part, you're placing that on the cheekbones of the victim or your patient. And with your fingers, you're going to reach behind the jaw, grabbing, where the angle of the jaw is kind of a couple inches below your ears, and you're going to pull the jaw essentially up back towards you. So that's essentially what that's doing, is displacing the lower jaw, which is what your tongue is attached to, in turn opening the airway and prohibiting the tongue from closing the airway. But that, again, is what we'll use in case of a traumatic incident, or if we suspect trauma. Shay, I don't play this video either, so it doesn't matter that it doesn't work, if we can just cut that out. Alright, so once we've already talked about finding somebody, we've talked about calling for additional resources, we've talked about different ways of opening the airway. Now that we have the airway open, we have to check the airway. It's not anything that's going to take a substantial amount of time. You literally just glance at the airway once you open it. It takes half a second to do that, and you're looking for anything that is possibly blocking the airway. So that could be anything from secretions, such as vomitus, mucus, or blood, as it says on the slide, or it could be foreign objects. Commonly it's food. Kids, definitely be like toys, Legos. I'm sure all the younger kids have that reflex of anything in their hand goes to their mouth. So looking for anything like that. And then you could have in your older generations maybe unsecured dentures, or even in traumatic incidents, right? Your natural given teeth could be an issue, as well as depending on what your injury is. If the person has bit their tongue, that could be an issue, and it could also be a free-floating obstruction. But if you do that airway check, like I said, it takes half a second to do. Once you open the airway, you look into it. If you do see something there in the airway that needs to be taken out, you would take that out using a finger sweep, or if you don't feel comfortable putting your fingers in someone's mouth, then you're using some sort of tool or instrument to scoop that foreign body out. with that said, you're removing anything in the patient's mouth if you see it. Under no circumstances should you do a blind finger sweep. What a blind finger sweep is not seeing anything in the airway, but just in case, putting your finger in or trying to scoop out anything that you might not see but might be blocking the airway, because the reason why we don't do that is we don't want to push anything that is deep in the airway even deeper in when we're trying to do a blind finger sweep. But if we do open the airway, once the airway is clear, if that person can't keep a patent airway, then what we'd want to do is think about placing an airway ourselves. So as an EMR, an airway that we could place is a nasal pharyngeal airway that's through the nose, or an oral pharyngeal airway, which is through the mouth. Got ahead of myself apparently. Finger sweeps, we talked about it. Finger sweeps can be done as long as you see something in the airway visually. We don't do blind finger sweeps. And suctions, we don't carry suction machines here at Manchester Police. However, there are several different kinds, everything from manual suction to battery-powered suctions. If you do find yourself in the position where you are going to suction somebody, just remember that we do not suction for any more than 15 seconds at a time, and you do not start suctioning on the way into the mouth, right? So if I have my suction and I'm using a rigid catheter suction, I don't start the suction process until I've already had put that catheter in the mouth and got it kind of to the base of their pharynx, and then I start the suctioning and start retracting slowly as I'm suctioning. So you don't suction on the way in, you only suction for 15 seconds, and you suction on the way out. So as you're retracting slowly and getting all areas of that airway, you're slowly pulling the suction out, and you're continuing to suction until you're out of the airway. I keep on getting ahead of myself here. So that's a manual suction that's depicted or illustrated on your screen right there. It's a picture of a bulb suction, right? So manual meaning that we're creating the suction ourselves. You squeeze, you put that suction catheter in the mouth, and then once it's in the mouth, you squeeze that bulb. And then once you squeeze it and release it, releasing it will create the suction, pulling whatever secretions into the catheter. So you would do that as many times as you need to clear the airway, using the guidelines that I have already stated, no more than 15 seconds at a time, and you're not suctioning on the way in. The 15-second thing is because if you're suctioning out secretions and things, especially with a continuous suction tool like a motorized or a battery-powered suction device, you're also going to be suctioning out air and oxygen as well. So you pre-oxygenate somebody by ventilating them, whether you're using a bag valve mask or a mouth-to-mask or mouth-to-barrier, but you give them some rescue breaths or some ventilations, and then you do that suctioning for no more than 15 seconds, and then you ventilate them again to get some more oxygen in them. If you have to go in and suction again, you just make sure you ventilate them a couple times, get them some oxygen before you go in again for another 15-second suction. I'm just going to talk about, we've already talked about the finger sweeps or suctioning, so we'll just skip over it. That is a picture picture of a battery-powered suction. So essentially turn that battery on there. That's what will create the the motor to create the suction. Then you'd put that long tube. At the end of the tube is where you would attach your catheter. So there's essentially two real different catheters you would use for suctioning. One is a rigid catheter, so it's like this hard plastic to get that, like that real chunky vomitous stuff. So got like a little bit of a bigger hole to get all that chunky stuff out of there. And then you could also use called a French tip catheter or a soft catheter, which is more for like your not so chunky fluids, so like maybe saliva, stuff like that. And it's more of a thinner tube, almost looks like an IV. You have your IV bag with that line that connects into your arm. It's like almost the same thing, as the same idea as that, just like a soft tube that you could stick to get more fluid, liquidy secretions. We've talked about it. If you have an unconscious person, you might have to maintain their airway for them because they're unable to due to them being unresponsive unconscious. So again, head tilt, chin lift, jaw thrust maneuvers are going to be your primary tool for that. And if needed, you can use an OPA or an MPA to keep that airway open if you're not going to keep it open yourself by holding that airway open. And then we can also use the left recumbent or the recovery position for somebody who's unconscious, unresponsive, that we're worried of them aspirating or choking on their secretions. So we could roll them onto their side and let fluids drain out of their mouth that way. Just kind of touched upon it. If someone's unconscious, not suffering from trauma, that's a pretty big thing. That would be if you're suspicious of trauma, of some sort of neck, spinal cord injury, then we don't want to start manipulating their body, because then we don't in turn want to move their neck or their spinal cord. So this is for traumatic patients who are unconscious, unresponsive. We could try to place them in that recovery position. If they are a traumatic, a patient that has possibly suffered trauma or has suffered trauma, and we're using spinal cord precautions, and you need to prop them on their side, then in the past, when I worked as a paramedic, I would secure that, put a collar on their neck to help prevent any further injury or to stabilize that injury, and then secure them to a backboard, and then you could prop the backboard on its side if you needed them to drain secretions from their mouth. But that's the safest way to do it. Just a picture to show what the recovery position does look like. Again, it's called the left recumbent, on their left side. Throw their hip over, so it's on like a 45-degree angle, and their mouth is towards the floor to help using gravity to have all secretions drain out of the mouth. So we've talked about the airway adjuncts. The two things that we have available to EMRs is the oral airway and the nasal airway. So the oral airway is used for unconscious patients because hopefully they do not have a gag reflex, where conscious patients are typically going to have a gag reflex. So if you have an unconscious patient, they're breathing, and we want to keep their airway open using an oral airway, we would take our oral airways out. We would size that oral airway so when we size an oral airway, it's from the corner of the mouth to the earlobe. That's how we would pick the appropriate sized oral pharyngeal airway. And then we would place that airway in their mouth. So you have two ways. So the natural curvature of the airway adjunct, as you can see, you want that natural curvature or the curve of the airway to go with the natural curvature of the anatomy, right? So what we would do is see how it forms like a C when you're looking at it. So what we would want to do is we would want that C to be facing either the top of the mouth, so you have to twist it 180 degrees as you insert it into the airway, or you would want that C to be facing the corner of the mouth, and you would twist it 90 degrees to form as you insert it into the airway. So the reason why you don't just take an airway, an oral airway, and just put it straight in using with the natural curvature of the airway is because if you did that, you would be pushing the tongue into the back of the throat and likely causing an airway obstruction. So the way to not do that is when you're either using the 180 degree technique or the 90 degree technique, you're pushing the tongue out of the way and slipping that airway into the space while you're doing it. Where if you just went straight in, you'd be pushing that tongue straight back into the airway. And then you can use a couple different things when you have an oral airway or a nasal airway in place. Speaking with the oral airways currently, you can use that in conjunction with a bag valve mask. You're pushing the air through the airway, which is kept open by that piece of plastic in their throat. Also, you can use a suction device when the airway adjunct is also in place. Now that we talked about the oral pharyngeal airways, we will move on to the nasal pharyngeal airways. Nasal airways can be used in both unconscious and conscious people because in some people you might be able to get that nasal airway fully into the nasal. You might be able to use that nasal airway to get fully into the nasal cavity without stimulating a gag reflex. In some people with a sensitive gag reflex, you might still stimulate that gag reflex by putting a nasal airway in, but it's far less likely than attempting to put an oral airway into a conscious person. But so if you're using a nasal airway, then you insert the nasal airway, and if the person does start gagging when you're inserting the airway, you just start retracting it until they stop gagging, and then you can leave it in place once they stop gagging. So that's as far as you're going to be able to get without them gagging. So you can leave it there even if there is like an inch or two of that nasal airway device hanging out of the nose. You still can leave it in like that, and it can still work for you. Don't suction through the nose. Usually we don't suction through the nose. Usually we only suction through the mouth. Using this proper airway adjunct is just going to be beneficial for appropriate size and fit to ensure or give a better chance that you're keeping a patent airway. So if we've already talked about the oral airway, sizing it from the corner of the mouth to the earlobe. With the nasal airway, because it's going in the nose, we will size it from the tip of the nose to the earlobe. Once you have the proper size, you want to lubricate the airway with, they should come with lubricant, with lube. Use that if you have it. If not, in past practice as a paramedic, I've used people's own saliva or blood, depending on what you have available to you, um, to use that as a lubricant. I just urge you to only use their bodily fluids, whether that is saliva or blood, and not somebody else's. So just make sure you try to keep the body fluids to that same person. But once you have that airway coated with your lubricant, then you want to insert the airway perpendicular to the face. So you want to essentially put it in at like a 90-degree angle. You don't want to ride the nasal cavity or the nasal passage, up into the nose and then into the back, because your nose is very vascular. You could cause some unnecessary bleeding, which, if it's bad enough, can in turn cause some sort of airway obstruction risk, or secretions that someone's going to have to suction out at some point. So if you can, try to go in perpendicular 90 degrees to minimize secondary injuries. And then you just keep on working that airway in until it rests, the end of the airway rests against the nostril of the person. Typically, the right nair is the bigger nair in most people, but so that's the one I would try to go with, their right side. But if the right side doesn't work, you can try doing the left side. Now, with that said, it shouldn't take too much force. I mean, you're probably going to have to wiggle it and maybe twist it a couple times just to get the airway in there. That's normal. But I mean, if you find yourself using a decent amount of force to try to get that in there, then there's probably an issue with the nasal passage. So if you find yourself using more force than just what seems kind of reasonable for the situation, then I would suggest moving on to a different, either a different airway, or I would stop doing that, because that might be an issue with or an injury with that patient. A contraindication to nasal pharyngeal airways is someone who has facial trauma. So we don't want to start pushing a foreign object into their nose if they have suffered facial trauma, because if they have a basilar skull fracture, then that there's a chance, depending on how bad it is, that your nasal airway can make its way into the skull, and we don't want that. So if there's any signs of facial trauma, that's a contraindication, and the nasal airway is not appropriate for that person. So when we talk about signs of adequate breathing, we'll just mainly talk about adults right now. That look, listen, and feel. So if you, first thing, if you look at somebody and you're looking for chest rise and fall, and you can see clearly their chest rising and falling with each breath, then they're doing pretty well. It takes a substantial amount of air to visually move that chest, to see the chest rise and fall. So if you see someone with chest rise and fall, then they're doing pretty good, moving some pretty good air. It's when you don't see that obvious chest rise and fall that you would have to start worrying about the quality of their breathing. So obviously chest rise and fall, if you have your stethoscope, which is in the EMS bags in the back of your cruiser, you can listen, auscultate for breath sounds. So you're placing the stethoscope over the lungs, and when you do that, you could hear this. Sounds like a wind tunnel. You just hear some air exchange or air moving within the lungs, and that's a good sign. If you don't hear anything, that's a bad sign. Diminished sounds is a bad sign. hear gurgling or the sound when you get your hair in between two of your fingers and rub them together, you have like that noise that creates is actually a sign of fluid in their lungs. That's what it sounds like through a stethoscope. But if you hear anything other than that sounds like a wind tunnel, then you have something going on. And then if you want to go for feel, you could put your cheek in front of the person's mouth and feel if they're exhaling. You can feel the breath on your face. I personally would not suggest doing that because you're putting yourself within inches of the person's face, and B, if they do vomit, then you're right there. So I would just err on the side of caution and not put my face or your face up against somebody else's that you don't know. Breathing rates, a normal breathing rate for an adult is anywhere between 12 and 20 breaths per minute. So with that said, as far as quantity goes, if we're not breathing enough, so like I said earlier in the PowerPoint, if you have that person breathing 6 times, 5 times a minute, even 8 times a minute, I'd be worried about their quantity of breathing. So I might be breathing for those people. Also, on the other hand, there's the people that are breathing 60, 70 times a minute, which is pretty impressive to actually see it. That's like once a second or even more. That person cannot sustain life breathing like that. So if you don't do something to stop that, which is I've, as a paramedic, had to breathe for people using a bag valve mask while they're conscious and they're breathing at 60, 70 times a minute to try to control their breathing. Typically people who are breathing extremely fast are extremely wound up and anxious also, so putting a mask over their face is not something that they're going to like. It would take a lot of coaching, but you got to try to get that rate under control, because once your body can't take it anymore, then your body's only way to try to remedy that situation is that that person's going to pass out, and the body's going to try to kind of adjust once that person goes unconscious. But then you'll be dealing with a couple other issues, I'm sure. So it behooves you to try to get their breathing under control as soon as possible. 12 to 20 breaths a minute for an adult. Signs of inadequate breathing. So we have already talked about those noisy respirations. I talked about gurgling, rubbing your hair in between your fingers. That kind of sounds a sound of fluid in the lungs. Wheezing, if you know someone or if you have asthma, then you've probably heard some audible wheezing before. Those are all signs and symptoms of maybe not even inadequate breathing at the time, but that there's an issue that needs to be corrected. Rapid or gasping respirations, touched upon both of those. Your gasping respirations are like your agonal respirations, where it's like one big breath every like 10, 15, 20 seconds, because the body's just about into respiratory arrest, not able to sustain life on that. Paler blue skin, so pale skin, okay, kind of self-explanatory. Blue skin, also known as cyanosis. Blue skin, you'll see it like maybe around the mouth, around the nose, fingernail beds. That's a sign that your body's not getting enough oxygen. So in those areas, you might see some bluish tinged skin. Obviously, the most critical sign of inadequate breathing is respiratory arrest, because respiratory arrest is no breathing at all. So that's no chest rise and fall, no breath sounds, no breathing whatsoever, breathing 0 times a minute. So we need to do something about that and do some rescue breathing for them before they go into full cardiac arrest if we don't do anything. Signs of inadequate breathing continued here. This is just going into different causes of respiratory arrest. So like I just stated, respiratory arrest means that there is no breathing whatsoever. Could be caused from so many different things, but here's a list of some things. Our most common one, because we don't go to medical calls typically, so the most common one that we're going to see is the overdoses, more specifically opiate overdoses. You can also get the respiratory arrest or low quantity breathing from benzodiazepine overdoses. So that's like your Ativan, Xanax, stuff like that, because all those benzodiazepines depress the body, depress the senses of the body and slow everything down, similar to opiates. I mean, we've already touched upon this in the beginning. You're going to check for signs of breathing. Typically, when you do check for signs of breathing or for signs of a pulse, you don't want to do that for any more than 10 seconds at a time, because if we don't feel anything after 10 seconds or see any signs of breathing, then we already know that even if they breathe after 10 seconds at 11 seconds, it's not going to be enough to sustain life. So look, listen, feel for no more than 10 seconds, and then get into whatever treatment that you need to rectify the situation. So we've, again, talked about this. If you're going to do mouth-to-mouth, make sure that you pinch the nose, and or if you have a smaller person or child, you might be able to cover your mouth with, cover their nose and mouth with your mouth, so you don't have to worry about pinching the nose. Or if you have that trachea or stoma, you're going to use whatever artificial respirations or ventilations you're going to do, and make sure you cover the mouth and the nose to make sure it doesn't go it doesn't leave the body and not go down into the lungs where you need it to go. So if you're doing rescue breaths, so we have someone who needs help breathing because they're not breathing, but they do have a pulse, so you're not doing CPR, you're going to do one breath every 5 to 6 seconds for an adult. I believe I've said that already, but one breath, that's very important. Rescue breathing, I'll give you a scenario that we'll see time and time again on a daily basis. Someone in a opiate overdose on the ground, they have a pulse, so they're still alive, but they're not breathing, or they're breathing one breath every 30 seconds. Then we're going to do one breath every 5 seconds using a mask, a bag valve mask, or a mouth to mask. And you do that until the paramedics get there and they can take over. So mouth to mask rescue breathing is the #1 best way to deliver rescue breaths for one rescuer. Back when we used to take tests for EMR research, that was always a test question. Mouth to mask is the best way, most effective way to deliver rescue breathing for one rescuer. So the reason behind that is you can use both of your hands to create the best seal possible around the mask and the person, and you're using your mouth to deliver the breaths. And that often gets confused with a bag valve mask. Everyone thinks a bag valve mask is the best way to deliver artificial ventilations, period. It is the best way to deliver artificial ventilations for two rescue breaths. So again, if you have two rescuers, you want to use a bag valve mask because one his only job is to use both of their hands to create a seal, a good seal around the person's mouth with the mask, and then the other person's only job is to squeeze the bag and deliver 1 breath every 5 seconds for an adult, 1 breath every 3 seconds for an infant and toddler. It's obviously inherently more difficult for one person to create a good seal using one hand and using the other hand to breathe using a bag valve mask. So that's why bag valve mask is the best, most efficient way to deliver rescue breaths for two rescue breathing. Mouth to barrier. So in your older CPR classes or EMT or EMR classes, they used to hand out. Now we hand out masks, right? We hand out the things to do mouth to mask, and because that is a safer way for the rescuer to deliver rescue breaths. Before, it used to just be that little thing you could put on your keychain, little pouch with a little flimsy, thin piece of plastic. That's your barrier. That you could lay over somebody's face, and then it would have a little slit or a little opening in it where the victim's mouth would go, and then you can breathe, giving you a little bit of protection because your mouth is touching the plastic barrier and not the actual person. But for obvious reasons, you're putting your mouth up to someone else's with a thin piece of plastic. I'm not very comfortable with it. I would prefer to do a BVM or a mouth to mask. It just gives you more protection. But just know that mouth to barrier is a acceptable way to give artificial ventilations. And then mouth to mouth, which gives you an illustration on the slide there. So that mouth to barrier, just picture a thin piece of plastic in between her mouth and the guy's mouth there. But mouth to mouth, again, you're breathing oxygen from or air from your mouth into theirs, but it still has enough oxygen to help oxygenate their body. 1 breath every 5 seconds. She's pinching the nose of the person because we don't want air to escape through the nose. We want it to all go down into the trachea and into the lungs to create that gas exchange. We just talked about it, bag mask device. We're putting that mask over their face, getting as tight and as good of a seal as possible, and then you're squeezing the bag to deliver the breaths or the ventilations. You don't want to squeeze the bag abruptly and with a lot of force, because then you're going to be pushing a lot of air into the trachea, which could possibly start going, or it could start going into the esophagus, and we don't want air to get into the esophagus, because then it will in turn get into the stomach, where at some point when there's enough air in there, it will cause the person to vomit. So nice smooth breathing, 1 breath every 5 seconds, and a smooth squeeze of the bag to ensure that we're getting air into the trachea and the lungs and not pushing air violently into the esophagus and stomach. Here's a picture of two rescue breaths using a bag valve mask. Once you guys start using the bag valve mask, you can, once you start delivering ventilations, you can then hook up your bag valve mask to a oxygen, and then you could be delivering up to, realistically up to 100%, but anywhere between 90 and 100% of oxygen to the person instead of the 21% in the regular air. And then, this is just a review of everything we've talked about. Checking for responsiveness, look, listen, feel, no more than 10 seconds for signs of breathing and a pulse. Open the airway ABCs, and decide, if any, what you have to do, whether that's breathe for the person, keep a patent airway, put in a airway adjunct, suction, finger sweep, all those things, and then make sure that they have a good rate of breathing. Performing rescue breaths on children and infants, it's all mainly the same. A few differences. The breathing rate, the quantity of breathing is 1 breath every 3 seconds for a child or an infant. The other thing is when you're delivering rescue breaths, so we've talked about head tilt, chin lift, and you're opening the airway to a child. The child's heads are typically bigger in proportion to their bodies than adults are. So we don't want to overextend their head backwards because their head is that much bigger. So a common, you want to typically keep the kids' heads in a neutral inline position when you're delivering rescue breaths. Also, a good way to get a patent airway with a child is to put something under the shoulders, like maybe roll up a towel or a piece of clothing to prop their shoulders up a little bit, and it'll open up their airway just a little bit, but keep their neck in the neutral inline position. And that'll be your best way to deliver airway there. Deliver ventilations and keep a patent airway. What you have to remember, in infants and extremely small children, if they're not infants, but they're just smaller in general, is like I said in the beginning when I talked about if you're looking at someone breathing and you see chest rise and fall and they're moving a good amount of air, if they're making their chest rise and fall, so that, like I said, that's a good amount of air and that's what we want. So if we're breathing for an infant, you're only breathing to see their chest rise. Once you see their chest rise, you stop that breath, because obviously my lungs as a 32-year-old male have a lot more area and a lot more volume of air than a 1-month-old, 2-month-old, 3-month-old infant, right? So I don't want to be putting 1,000 cc's of air into the lungs of an infant where they can only hold 200 cc's of air. So you're just delivering, whether it's you're breathing for them mouth to barrier, mouth to mask, or you're using a bag mouth mask, you're only giving a breath until you see chest rise and fall, and then you stop that breath. 1 breath every 3 seconds. Most common airway obstruction is the tongue in general. So we want to open their airway, like we've already said. In kids, we are more suspicious of them putting something in their mouth and having it be a foreign body obstruction. So keep that in mind. Utilize your finger sweeps if applicable. No blind finger sweeps ever. And if you do have secretions or vomitus or some sort of more liquid obstruction, then we're going to be suctioning. No more than 15 seconds at a time. Don't suction on the way in, only suction on the way out. Just a couple illustrations of different types of airway obstructions. Top left corner, you have your tongue blocking the airway. Obviously the obstruction part is the darker red. In the lower left, you have the swelling of an airway, which is narrowing the airway passage down in the larynx. Top right is an injury to the airway, which is causing the obstruction, and bottom right is a foreign object occluding the airway. The universal sign for someone choking is, crossing their arms and putting both hands at the base of their throat. That's just typically what people do when they're choking. It's the universal sign. So typically you walk up to that person or If you believe someone's choking, you ask them if they are choking. If they tell you they're choking, then it's not a full airway obstruction because they're able to move air enough to make their vocal cords work and speak to you. So I'm not saying that they're not choking, or have an airway obstruction, but it's a partial at the most, because if you had a full airway obstruction, air wouldn't be able to pass through the vocal cords and they would not be able to speak medically. If the patient can cough, that's again a sign of a partial airway obstruction. And then again, your mild airway, or you're on the spectrum of partial airway obstructions on the lower end. If they are able to speak in a couple word sentences and things, and it's not a significant airway obstruction, so you're mild. If people can cough, you encourage them to cough. Some people will try to do minor back slaps, or if you're alone, some people will put their chest, sit backwards on a chair, so like their chest is up against the back of the chair, and then make the chair fall so that they're using the chair to try to expel whatever is in, almost like a makeshift Heimlich. So obviously for severe airway obstructions or complete airway obstructions, what you're going to want to do for that person is the Heimlich maneuver, and you're doing the Heimlich maneuver until either the person expels the foreign object that they are choking on, or the person goes unresponsive. In that case of unresponsiveness, you would lay the person supine, so on their back, face towards the ceiling, and you'd start giving your chest compressions there. The only difference between CPR for a choking person that is unresponsive is you're giving your chest compressions to try to free the obstruction, and after giving your chest compressions, you're going to look in the airway before giving breaths to see if you have a visible obstruction that you can use a finger sweep to get rid of. For your smaller children, like infants and between infant and toddler, there you're gonna do for choking, like a full obstruction, you're gonna do your alternate between your 5 back slaps and your 5 chest thrusts, and you'll do that until the object is expelled, or until they go unresponsive, and then you're going to move again to like your chest compressions. And then for your smaller children, you're doing your back blows, and then your if they go unresponsive, your chest compressions. Oxygen cylinders, we carry Class D oxygen cylinders in our medical bags. It holds approximately 2,000 psi of oxygen. Our oxygen cylinders, as depicted in the picture there, look very similar. You have the regulator on top with the gauge that tells you how much oxygen you have left in the tank. You use the regulator to choose what amount of oxygen you want to deliver per minute, and depending on what non-rebreather mask or nasal cannula or whatever is going to decide on your oxygen flow. It's your regulator, you adjust it anywhere from 2 to 25, I think they go up to. If your oxygen cylinder isn't open, then if you have to open it yourself, you'll have an oxygen key, or you should have an oxygen key attached to that oxygen, and you only have to open it like not even a full turn. You just have to crack it open. You don't have to open it all the way. Um, then you would attach your whatever avenue you're going to deliver oxygen to. So your nasal cannula is this little two prongs that go into the nose, and then the tubing you would wrap around the ears. That's going to deliver your lesser amount of oxygen for mild cases of difficulty breathing, or maybe some cardiac event. You might put on a nasal cannula. Again, for like your minor cases. Oxygen is supports combustion, so we want to keep it out of the way of fire. We don't want anyone smoking near oxygen, things of that nature, because we don't want that to support combustion and then cause some more injuries. But your nasal cannula, you want to do anywhere between 2 and usually 6 is kind of the highest you want to go. If you're going to use a nasal cannula, liters per minute, because if you start going any more, I mean, that's going to dry out your nostrils, not in the short term, but if they have it on for an extended period of time, blowing dry air or dry oxygen into their nose any more will be extremely uncomfortable, dry out their nose, could cause bleeding. But you're going to, at between 2 and 6 liters per minute, you're going to deliver about 35% to 50% of oxygen into the body. So usually 2 or 4 liters per minute are what you're going to do for someone with a nasal cannula. You have your non-rebreather mask. Important, when you open the non-rebreather mask, you plug in the non-rebreather mask to the oxygen cylinder. You want to put your finger over the one-way valve in the mask to fully inflate that bag attached to the mask, because in people with serious difficulty breathing that you're going to use a non-rebreather mask on, they're going to be breathing in the oxygen from that bag, and people who are really in need of oxygen and that are having difficulty breathing, they'll collapse that entire bag that is full of oxygen with one breath. So that's why it's important that you fill that bag up before you put it on their face. When you're using a non-rebreather mask, you're going to anywhere from 8 to 15, usually 10 to 15 liters per minute are the settings you'll use it on. Delivers up to around 90% oxygen. And again, you're using those for the people that are have signs and symptoms of difficulty breathing, that are in need of oxygen. Just another thing that we talked about the oxygen can support combustion, and also try not to stand the oxygen tank up, so it's knee high, you know what I mean? So like, we don't want I'd rather lay the cylinder on the ground sideways than stand it up, because if someone knocks it over or kicks it over and that regulator hits the ground just right and detaches from the tank, then that tank can get, depending on how much oxygen is in there, can get sent similar to a missile and across the room, and can come at somebody with some force. So you want to lay it down so it doesn't get knocked over. Pulse oximetry is evaluating the how much blood is in a person's how much oxygen is in a person's blood. So they do that by we don't have them, so I don't know if anyone's ever really noticed what they are, but it's a little probe that goes on to the person's finger and essentially just reads the red blood cells in the person's blood. So a normal person will have anywhere between 96 to 100% oxygen saturation. Anything under 96%, you wouldn't be wrong to deliver oxygen to them. But people that are really hurting, that are having some trouble breathing and aren't getting enough oxygen in their blood, will be like under 90, even in the low 90s, but definitely under 90 in the 80s and such. I'd be extremely worried delivering them high flow oxygen, and they're going to need some treatment from a paramedic and a doctor. So it's just a tool. It's not always accurate. Pulse ox can give incorrect readings for people who had lost a lot of blood. Will give incorrect readings. People with nail polish, sometimes people with cold fingers, dirty hands, because you're putting it on a finger and trying to read the red blood cells inside the blood using infrared. So anything that and high carbon monoxide poisoning will also give false readings. So you're using it as a tool if you do use it, and you're not going to solely rely on treatment based on what the pulse ox says. You're going to look at the person, the totality of circumstances. What are they complaining of? What are their signs? What are their symptoms? How do they appear to you? Are they pale? Are they cyanotic? And their pulse ox is low, then I'd say that the pulse ox is probably correct. But if the pulse ox is reading in the low 80s or high 80s and the person seems fine, then I would say that there might be, I wouldn't go off strictly the pulse ox in that. Again, those are just the things I talked about where it could give inaccurate readings: nail polish, dirty fingers, cold, loss of blood, carbon monoxide. I did touch upon the stoma and trach things when we were talking about rescue breathing earlier. So I guess as a review, if someone does have stoma or trach, that any airway ventilation that you do has to be through that. Also, if you're going to suction someone, you're going to be suctioning through that, and essentially all your treatments are going to be through the trach or the stoma and not through the mouth or the nose. Again, if you're giving rescue breaths or rescue breathing, artificial ventilations, you're doing that via stoma. Place your mouth over the stoma, use the same procedures as mouth to mouth, and to make sure that you cover the person's mouth and nose so air doesn't escape that way and it's all getting pushed into their lungs. Gastric distension, I did touch upon that when I went over the bag valve mask breathing. That's why you don't want to do like these rapid, violent squeezes of the bag, because if you start putting a lot of air into the stomach, you'll get gastric distension. Bad gastric distension, you'll actually be able to see it. You'll just see the belly getting bigger and bigger and bigger, and at some point, because it's filling up with air, it's going to let go, and you're going to probably get some vomiting along with it. Dental appliances, if they're in place and someone has dentures, do not remove them. You only really have to worry about them if they are causing some sort of obstruction or choking hazard. If they're partially coming off, then you can remove them. But if everything's in place and normal, leave them be. Jaw thrust maneuver. You can do both maneuvers actually, whether they're laying down or in a seat. So there's really no difference in them. Just a picture to show the head tilt chin lift. And again, your respiratory system, I think the biggest highlights are the rates in adults. 12 to 20 breaths per minute is what we're looking for. If they have anything substantially less than that or substantially higher than that, then you might have to think about providing some artificial ventilations for them. And then just making sure that people have patent airways that we're dealing with, and always reassessing.